It's just so moving. I'm like kind of tearing up a little bit thinking
Hmm.
about how powerful that is for people to like have so much agency. Like I feel
Hmm.
like I don't know about you, but I feel like when I was a brand new grad, I was like keeping my head above water. Well, hey there, it's Liz Rohr from Real World NP, and you are watching the Real World NP YouTube channel. We make weekly episodes to help save you time, frustration, and help you take the best care of your patients. Oh my goodness, I just had the most amazing interview. So I interviewed Meghan Kavanaugh. She is a nurse practitioner who specializes in diabetes care. And we collected questions from the real world NP community and asked some of the heavy hitting questions. Things like how to help patients who are not adherent with their medications, how to navigate cost challenges when it comes to diabetes care. And we also talked all about continuous glucose monitoring, which was just so helpful because that's a tricky thing, but it's actually in the guidelines recommended for anybody who is approved by insurance, which is something we also talked about. We finally talked about the pearls of practice that she had to share for nurse practitioners and clinicians in primary care. It was so good, and I could literally talk to her for hours and hours and hours. And so before we get into the interview, I want to let you know that the diabetes, hypertension, and CKD course that we have here at Real World NP is coming up for re-release oh so soon, and there may be some bonuses in there to be able to ask some of your clinical questions for your specific patients when it comes to care of those patients. So if you haven't gotten on the wait list already, head over to realworldnp.com/courses. And if you're watching this at the time later than the recording time, definitely go check out the same URL and you will find the course there for registration. So without further ado though, I'm going to share my interview with Meghan. Thank you so much for being here. Can you introduce yourself?
Yeah. Well, hey, thank you for having me too. I love all your content and thank you for what you do for the community for NPs. My name is Meghan Kavanaugh. I'm a family nurse practitioner. I work in North Louisiana at a clinic that is pretty much diabetes only, but we all know it's not just diabetes. So we end up treating other things, of course. But my original background is nutrition. I'm also a registered dietitian. I finished in 2008 with my RD and I finished my master's. I practiced for a few years and kind of got to the point of I want to be able to do more. I was in a great position in an outpatient diabetes education center, but it was education only and there was no management. So we were really limited on what we can do. And I really wanted to get to that point of being able to do more for my patients, but besides just the education. A few years after that, I decided to go to RN school, practice for a few years, and then just went to NP school. So I've been practicing as an NP for about 3.5 years. I've been at the clinic that I'm at now for almost 10 years. We've been open almost 10 years. So it's
Wow.
been great.
I have a
So
feeling you're like a person who really likes to learn.
yes, absolutely. I am. I'm a nerd. Doesn't bother me. I read all the time. I read everything. I read formularies for bedtime stories.
Oh
So,
my God, I love it. I love
yeah.
it. That's
So
so awesome. We had so many fantastic questions come in from the real world NP community. So we've tried, you and I, we talked before the recording, but tried to narrow it down to some really key highlighted points that are like real world applicable, tricky. Right. So one of the first really common questions is about continuous glucose monitoring, CGM.
mhm.
So I feel like especially if you're thinking about the place of a new grad or a student, like almost like what guide if you can you just talk about what that is and guidance about like how to use it and how to prescribe it and how to get it covered as
Sure.
best you can, because I know you practice in Louisiana and nationally
Right.
there's different rules, but
There's differences. And luckily, we're at a time now that a lot of insurance formularies are way more generous than what they used to be. So when CGMs were first released, it was strictly for type 1 diabetes. You had to have a history of like severe hypoglycemia unawareness, potentially like loss of consciousness or causing seizures. It wasn't open initially for like type 2 diabetes, but now we have much more flexibility, thankfully, because it is such a wonderful tool for somebody who's not really familiar with the CGM. CGM is a continuous glucose monitor. And there's several different brands. Probably the top two that you hear about, of course, are Dexcom G6 being the newest one, and then the Freestyle Libre. So there is a difference with the Dexcom. That's a continuous, it's a real time. So for this device, it's Bluetooth to a device, usually cell phone for most people. So there's an iPhone app, there's Android apps as well, and it's real-time data. So it checks sugars every few seconds. It averages about every 5 to 6 minutes. So I tell people, I'm like, you can open your phone and look at the app and stare at it, and you'll watch it change. So I mean, it's just like real-time data. The accuracy over the years has just gotten so much better. I mean, used to, we couldn't say, hey, you can make treatment-based decisions based off of this number. You still had to perform a finger stick. So for somebody on insulin, or if they're treating a hypoglycemic event, we couldn't say, hey, trust it, but now you can. So the Dexcom G6 is factory calibrated. For the Freestyle Libre, that is one that it also now has an iPhone app. There's an Android app. Both of them, sorry, the Dexcom has a receiver. If they don't have a smartphone, the Freestyle Libre, they can have a reader, but that one you have to scan to see what it is. Okay. So instead of opening up Dexcom and saying, oh, I can stare at this and see what happens, the other one, you do have to take that extra step, which is not a big deal compared to doing a finger stick glucose.
For real.
Grab the reader, scan it, and you can see what it is. But the newer versions of the Libres will alert for a low and alert for a high, but you have to scan to get that actual data.
Oh, so it'll beep if it's low, but they just won't tell you what it is, and then you
correct
to scan it. Okay.
Correct. Yeah. So with one thing too, and I will say this about the Libre, because that's one that is a decent option, cash pay for a patient that if they don't have the insurance coverage, or if they're paying an equivalent amount in testing supplies, that might be a great option, because then they don't have to buy the strips and the lancets and the new glucometer and everything, or they just want to pay for the convenience. So we do have a lot that are like, it's worth it. It's worth the $80 a month. Let me just go and purchase that, and then I don't have to worry about the finger sticks.
Yeah, you say it's $80 a month?
Estimated. Sometimes it goes up to about around here is between like $80 to $100 cash price. And that's generally for 2 sensors. And each one is one for 14 days, discarded, a new one's activated after 14 days. So they get 2 per month. So it's a decent cash price option if the insurance doesn't cover it. So with actual insurance coverage, most insurance formularies, at least in our area, require the patient to be taking multiple daily injections of insulin. So that could be a basal bolus regimen if they happen to be on like a Humulin RU500, even 2 times, 3 times a day of that, that's still MDI. Some insurance formularies do require some type of history of hypoglycemia and or hypo unawareness, meaning the person has had enough lows that they just don't feel it anymore, which of course is a really dangerous situation. So it really helps to justify that need. But I will say for this, with like the costing coverage, all of these companies have really, really good reps that are there to help the clinician and to say, hey, look, to get this covered, I mean, you have to have that documentation in your note of this person's on insulin QID, and they're willing to use the technology as intended. They're able to use the technology. They have the hypoglycemia, and that helps build the case, especially if that's for DME, durable medical equipment. Okay, so pharmacy.
It's in the cover. So the actual device is considered durable medical equipment.
Depends on the formulary. Yeah. But more it's all great, right? It's all great. So many more now is they're covering it under pharmacy, meaning if they have a Walgreens, Walmart, CVS, even a lot of the smaller town pharmacies, they can get it and it goes under their prescription formulary. So you send it in to the pharmacy just like you would anything else.
Yeah. That's how it works. How it's typically worked in my clinic. I'm in Massachusetts. Yeah.
So, and then if it does go through DME, then you'd have to go through a supply company, but it just depends. Like in Louisiana, our Louisiana Medicaid, thankfully we can get it under pharmacy now for most Medicaid. So that really helps a lot in clinic because
Yeah.
it's just a PA instead of doing a lot of the other paperwork.
Yeah.
And it's easier for the patient because they're not waiting on a supply company to mail them supplies. They can go through the Walmart drive-through and pick it up just as if they're picking up their insulin or any other medication.
Totally. And just to clarify, I remember being a new grad and being like, what is DME? So
Yeah.
so like what my, and I think this is so state to state, but durable medical equipment is like if you had compression stockings, at least this is Massachusetts, but compression stockings, walkers, chairs in the shower for people who are at fall risk, you have to go through a separate company. And this I always ask the nurses that I worked with, I'm like, how do I order this?
Yeah. Oh, absolutely.
And he was
Yeah.
like, this company, this is how you do it.
Uh-huh.
That's what that means is that is going through that process. And then various insurances have various coverage of drugs, pharmacy versus durable medical equipment. And it depends on
Right.
the insurance, which one is
Right.
which for the CGMs at least.
Right. And I will say this too, like I am somebody that's like, it's not a no until it's a real no. So I will send it under pharmacy
Yeah.
first because that's going
Yeah.
to be
Mhm.
easier.
Mhm.
Our EMR will, even if when the insurance information is input by the front desk, we can even search and look to see potential cost variant differences if they pick it up local retail versus doing Express Scripts or Optum Rx or CVS Caremark. And so
That's in
then
your EMR? You said that's in your EMR. That's amazing.
yeah,
What
EMR,
is
EMDs.
Oh, interesting.
Have
I
you
don't
heard of that?
know
Yeah.
that.
Yeah. So if everything's input correctly, which again, it's like if, and then if, magical, like we think insurance is one thing and then they end up with a $5,000 deductible and you're like, okay, whatever, that's
Yeah.
another problem. But,
Yeah.
um, so then it's knowing how to prescribe it. So
Yeah.
for example, with, the Dexcom,
Yeah.
there's typically three components. So it's the receiver, which used to, and and honestly, I would have to double check on this. Used
Yeah.
to, they would require the patient to get the receiver in case
Oh, the
the
Bluetooth doesn't
iPhone
work.
did not work.
Yeah.
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 So they would have to have something,
Mhm.
and that might be more under the DME side of
Yeah.
it. So you have one receiver, which depending on their insurance, they might only be able to get one every 2 years, 5 years, whatever it might be. You have the transmitter, which is the little gray piece. That's the one that's reused. It's a 90-day battery.
Okay.
And that's one for every 90 days. So they only have to get that quarterly. Okay. Because they
Mhm.
reuse it. That's the expensive part. Tell them don't throw that away when you change it out. That's it's expensive
Totally.
trash that you throw away because you got to pay cash for the next one if you lose it. And then the sensors are 10 days each. So you would dispense three for 30 days.
This is Dexcom.
Dexcom, correct.
I'm
Correct.
gonna,
So
for people who are listening or watching, this is gonna be all written down on a PDF for you to
yeah, and
download.
I'll help you with that if you need help.
Okay.
And then because with certain things like we probably won't get into like insulin pump therapy today.
Yeah.
Insulin pump therapy you can prescribe based off of how frequently they change their site based off of their total daily dose of insulin. So if you have somebody that uses quite a bit more insulin, they might need to change their insulin pump site every 2 days.
What
Okay,
do you
so you
mean?
have some wiggle
Oh,
room.
oh, oh, I see. I see.
Right.
Insulin
But
pump,
like
not the
Dex,
monitor. Yeah.
correct, correct. So there you have flexibility. Other devices like a Dexcom or Freestyle Libre, three for 30 days, two for 28 days for Libre, and there's very little wiggle room. So then you make sure to tell the patient, hey, look, there's Dexcom customer support, there's Freestyle Libre customer support. If something happens and you're new to the product and number one, maybe one just goes bad and it doesn't work. If you
Yeah.
wear that sensor for 2 days, you're going to be 8 days short before you can get your next one. So you can contact them and they're great about really troubleshooting that. So just to kind of think of that too. And so let me get into a little bit of like the management of it. Because if you look, I was going through all the guidelines and just kind of like doing a refresher. And I'm like, oh my
Yeah.
gosh, this thing is like 1,000 pages long.
It's so
But
long. I read it cover to cover for the course.
oh my
Yeah.
gosh, yeah, it's
Wild.
unreal. Yeah. So what I like to tell patients going into a CGM, because I have some that come in, they're like, I want a Libre or I want a Dexcom.
Yes.
It's like, hey, great. Like, let's get you some diabetes technology. Let's make life easier. Let's get away from these finger sticks.
100%.
What can be so overwhelming for them, amongst many, many other things, when you get a CGM and you have that real-time data, or if you're doing the flash and you're scanning, all of a sudden that patient is able to see what's going on all the time. So when you prescribe that, and then if you start it yourself, if they come back, for the education, or if they self-start at home, and you get a phone call within 24 hours and that person's A1C was a 9,
Yeah.
and they're on meds and all this stuff. Oh my gosh, Megan, my sugars are X, Y, and Z. Hey, you know what? You're seeing what has been going on. This is not new information for your body. So it's like you're just now able to see in real time what has been going on. And now we can see clinically when you come back how your meds are working, what's going on with food, your different triggers. Is it stress? Is it illness? Is it caffeine that's spiking you in the morning with your 2 cups of coffee? Is it, smoking or dipping or, anything like that? But they can see in real time what's going on. So it can be overwhelming. It's good information, but it's a
Like too
lot of
much for some
information.
people. I was gonna say,
Yeah,
like,
yeah.
one of the things I've been doing, especially with the team on Real World NP and like otherwise, is like recognizing people's way their brains work, basically.
Hmm.
And like for some people, they get really into details and really obsessed with them, and then other people
Absolutely.
don't
Yeah.
care. So
Yeah. Yeah.
and that might be hard to assess when you're starting with a patient, but like that might be a helpful question of like,
Hmm.
do you get really into details or not? Like
Hmm.
warning them
Like,
in
do
the
you
first.
like data? Yeah.
Yeah, do you like some people are data nerds, right?
Oh, absolutely.
Myself included.
Absolutely.
But yeah,
Yeah.
like is this like that? I guess like a pearl of that is like warning people to start that it can be scary to see
Hmm.
that. And like we are comfortable with that as clinicians because we understand that, right? We understand what
Hmm.
AMC of 9 means, but they might not.
Right.
And
Right.
yeah, and then just talking about that. Sorry, go ahead.
Oh, yeah. And I would say on the flip side of that too, I can't even tell you how many times that this has happened that, we started Libre, even, talking about somebody paying cash for a Libre because maybe they're not on insulin and it's just, or they're just on metformin and a GLP-1 and they're like, I just want to see what's going on. I want to pay out of
Yep.
pocket and do it. Sometimes, or not sometimes, a lot of times, once they get that data and they can see, I thought a banana wouldn't spike my sugar. I thought this wouldn't spike my sugar. They will come back on paper, we'll upload that report. You would have an A1C of this. And I have to double check, you should anyway, right? Their name and date of birth. And I'm like, are you the same person? Because you don't look like this 12A1C. I mean, you're flat as a board. And they're like, well, yeah, I could finally see what was going on whenever I ate X, Y, and Z. And, as humans, we crave success and you get that instant gratification of, oh, wow, like I did not realize that sweet tea did this to me. Like, let me cut that back. And then all of a sudden there's a flat line instead of a huge surge. So the data is great. And also for the data for the NPs out there, for Dexcom, when they download it on their app, they have their main app, which is their Dexcom G6, but then there's a second one, and I can give you this information called Dexcom Clarity. So that is where you get your reports. If there's not a capability in clinic to have like the clinic Dexcom account, they can from their app just email you the data and it's a PDF. And so the clinic side of it is not anything different than what they would see on their app. So it's not just like, hey, put the CGM on, good luck. You really want to be able, hopefully have the capability to go through it with them and be like, oh, what happened here? Like, oh, I had COVID and, and my sugars were sky high after I had to have, treatment or just the illness itself. So that way you can really look at the data. And then there's also the software for the Libre too. So I see that a lot. Like sometimes patients will come in, from primary care and internal med, and they're like, I have this data, but I've never been able to see my report before. And then just having that besides the real time, but like the actual like summary. And
Yeah.
as what's really cool and so rewarding for us too, I mean, like we want to fix people, right? Like we just want to fix it, is that when they wear each one of these for 2 weeks at a time, you get what's called a GMI, which is a glucose monitoring indicator. They can't call it an estimated A1C anymore, but it pretty much is an estimated A1C. And so they see that. And I'm like, oh my goodness, your A1C was X, Y, and Z when you came in. And look, now it's down to a 6.2 just in the last 2 weeks. And, again, it's really, really rewarding. And also, obviously, whenever you see it, and especially patients who are on MDI, really helps you pinpoint, do they need a different amount of insulin for this trigger food or this situation? Or you can on those two, you can literally watch when like GLP-1s kick in, you know, when they get to a higher dose. Like
Oh
it's
my
the
God.
data on it is fantastic.
That is
So,
like, it's just so moving. I'm like kind of tearing up a little bit thinking
mhm,
about how powerful that is for people to like have so much agency. Like I feel
mhm,
like I don't know about you, but I feel like when I was a brand new grad, I was like keeping my head above water. And
yeah,
you still make an impact from moment one. And even though it's hard to
mhm,
do for a lot of new grads, but I feel like the more time I have as a clinician, it's like, I don't know, I just feel like it's so special. It's just like
mhm,
those are the things that are just so special about like really like the focus is less on keeping your head above water. I'm like, oh my God, what am I supposed to do here? And more on like how can I empower my patients? Like
absolutely.
keep making that impact, right? Like I said, you
Mhm,
make the impact the whole time, but like once you like my frame of reference now is not just all the foundational stuff of medicine, but it's like how can I help people yeah, like empower them. So
mhm.
that's so, so special.
Oh yeah. And just so much of that, the cause and effect. And
Mhm.
we, you know, with our clinic, like I said, we're diabetes only, and I've been doing diabetes since '08. I mean, like kind of ages me out, but you know, so but you people crave success. Like they don't want to have go pay a copay or pay a deposit on deductible and just get fussed at. And you know, it's like maybe they just don't have the right tools in the toolbox. Like what let's reevaluate. Like if you need a hammer, a screwdriver's not gonna cut it. Like let's get them a hammer. Let's get good meds. And I've had people before be like, you know, my even endocrinologist, my endocrinologist, you know, I just see him twice a year and they just fuss at me because my A1C is still a 9. Please don't fuss at me. And I'm like, do I fuss? Like, have I ever fussed? I mean, it's with love if I do. I mean, we call it like, you know, something nice and then fuss and then, you know, do a little fuss sandwich. But, you know, it's with love and it's not demeaning and it's more about empowering that patient and just helping them learn what's going on, you know, because
Totally.
they're doing their own management most of the time. They see me for a little tiny blip in the radar in their lifespan. So
Totally. And
yeah,
you use the acronym MDI. Is that what you said? MDI?
MDI, yeah,
What
multiple daily injections of
multiple
insulin.
injections?
Yeah,
Perfect.
yeah,
Cool.
yeah,
Awesome. So thank you so much for all of that. I just think you were such
yeah.
just a gem and such a wealth of knowledge. I another question, super, super, super common question is about
Mm-hmm,
adherence,
mm-hmm,
and how to help patients when they are non-adherent. And I'm using the adherence language. We talk
mm-hmm.
in the diabetes CKD hypertension course that I have. I talk about language with patients, and the way that you talk with them actually does make a difference on outcomes. There is research on that, especially
Absolutely.
in diabetes. I
Yeah.
don't know, I'm sure you've seen that, but using non-adherence instead of non-compliance. So for patients who are struggling to follow the agreed upon directions that you've talked about, what guidance do you have or approach or thoughts? I mean, you kind of mentioned a little bit with like the hammer and the screwdriver, which you had told me
Mm-hmm.
before, but what are your thoughts
Yeah.
about that?
So I love that you use non-adherence too. I don't say compliant, you know,
Yeah.
and I don't know if y'all use this, but sometimes, unfortunately, I do have to put that ICD-10 code of like the non-compliance, you know,
Yeah,
because
I know.
it covers your rear end.
Yes.
You know, if somebody's just
Yeah.
literally you're just at a point, and I tell them they're like, hey, look, I'm sorry, like to
Mhm.
cover me, you
Yeah.
know, and just do that. I have to put this in. So it bothers me that that's still in the ICD-10, but
Mhm.
I use adherence too. So and just forgive me if I'm long-winded. So
Oh,
to
no,
stop.
everything you're saying is like so beautiful. And also like it's a lot of information. And I think I struggle with that too. And at least in my teaching is that like there's so much to say, but you're so concise. So go for
Okay.
it.
Okay. So years ago, this is something that has just stuck with me. And I probably just need to call this professor and just thank her. When I was in my first undergrad program, at Louisiana Tech here in Ruston, one of my favorite nutrition professors. She was teaching one of our MNT classes, and one of our big projects was to do a project about renal diet. But it's not just no renal diet is one of the most difficult diets out
Yeah.
there. I mean, I mean, just I commend anybody that can follow that diet to a T. I know this isn't diabetes, but one of the things she had us do with the project was to really put our feet in their shoes and say, okay, it was brilliant. I mean, now granted, this is an undergrad nutrition program, but she did use candy. But she, for each one of us, had different little baggies of all the different meds, what it would represent that that person that was on dialysis had to take on a regular basis. Then, so we had to keep a diary of what we ate and then track too, like how much potassium and phosphorus and calcium and, all this and protein and fluids and take your meds. Did you miss your binders? Did you miss this? Did you take this? How much fluid? And that has stuck with me now, oh my goodness, 15, 18 years, because it's so, when we think about adherence, it's like, what does that mean? What is your, like, as an NP, like when you're looking, okay, what do I expect of this patient? Are you expecting perfection or what's realistic for the patient in the season that they're in right now? Okay. So when we get referrals, we don't require referrals, but when we do, I mean, it's not a lot of primary care that are sending me their A1C patients of a 6.2. It's the one that's so high it won't read and it has to be a sent out. So it's a greater than 15 or, whatever. And they're just non-compliant, non-compliant, non-compliant. And you really just say, okay, let's think about when that person gets the diagnosis and what's their frame of reference of the diagnosis, right? Did they have a family member that they saw just suffer and have every complication in the world? And, they're like absolutely terrified and maybe they're motivated or maybe there's a little bit of denial in there. Is it, it could be anything. Is it they just lost a family member? Like what is going on with that patient? And it's, I try to tell, especially like our ancillary staff, this that and I'm going to kind of mainly focus on like more difficult regimens, like the MDI, the multiple daily injections. And when we recommend, okay, you're going to take metformin, you're going to do a weekly semaglutide. We also need to do a Jardiance. Okay, so maybe we can get some combination meds, but you know what? You also need a basal insulin, and then you need 3 injections per day. You need to do finger sticks because we haven't got your CGM covered yet. And then you literally have a life and you have a family and you have kids.
By the way, you have a life.
Yeah, like let's exercise too. Like, let's do that. Let's get good sleep. Let's meal prep. Let's count our carbs. And to the ancillary staff too, I'm like, have you ever thought about how difficult that is? We have other things to think about than dealing with daily chronic illness, right? So we have to recognize and tell that patient, like, this is hard. What you are doing is hard. This is a time commitment. And plus, with us, we make them keep homework. So they might not have had to write down their meals and snacks and try to count their carbs and do all this. We stress the importance of it. It's like, hey, do your best. But if we really step back before we just start fussing and we're just like, okay, you got to do it. You got to do it. Have we thought about like the time commitment that it takes to really just do what needs to be done? And we have some type A patients that are like, you know what? You just tell me what to do. Tell me what to do and I'll do it. Okay. I was like, I can't remember the last time I've taken a multivitamin daily for an entire week, let alone like a really complicated med regimen. So and it could be too. I mean, we all know the benefits of goal setting. So it might be, hey, look, right now, here's what I want you to focus on. No sugary drinks except for in the case of hypoglycemia. Okay, let's just work on that. Take your medicines as prescribed and check your sugar. I mean, like you can start with 3 things before you just like start pounding on all these other things. Then guess what? They got to get that dilated eye exam. You got to get the monofilament. You got to do daily foot checks. You got to do this, this, and this. Not to mention if they need a nephrology referral, cardiology, whatever, and then they have extra out of pocket. Yeah. So it's a lot. So if you say, I get it, this is hard. This is hard. This is brand new information. Let's work on this first, because, I'm in Louisiana. We have fantastic, great, fatty, wonderful foods. Like I can work with gumbo. I can work with chicken strips. I can work, with a crawfish boil. I can't work with Coca-Cola. I mean, like I just can't. Like I will dose it if I have to, but there's no place for that. Like
I love it. I love that.
Like,
because you're meeting somebody where they're at,
Yeah, absolutely. So, and then you just try to build on that. And then once they get that trust, maybe the last few places that they've gone, they've just been really kind of talked down to or whatever. And then they get that trust with you and know that they're coming like for encouragement, but also tough love when needed. You'll see more and more adherence if it's not mainly something like a cost issue, you know, which we'll talk about that in a minute. And also, too, I've had patients come in, you probably have too, that, you know, they'll say, well, I'm just in denial. I'm just in denial. I'm like, but are you in denial? You walked in the door. You came to a diabetes clinic. Like, I think you're in denial. I think, you know, let's recognize that you came in, you made an appointment, you paid your copay, you walked in, you were here on time, and you're talking to me. I don't think that's denial. So it's just like, maybe you just need different tools. And that's when, too, you go back to like something like a CGM, you know, something that, okay, maybe this person, we can get more data. It makes it easier on them. They can trust their med regimen. Maybe they were on really old school diabetes meds in the past and they're like sulfonylureas and we're dropping out like crazy. And maybe they're so terrified of lows and they're like, I'm worried about this SGLT2 causing lows. And then, so maybe it's just something like that where they just need a little bit more education on the mechanism of action of a medication. So, but it's just like, what is that adherence? I mean, like, what are your expectations of the patient? They really meet them where they're at.
Absolutely. Yeah. So just a couple like pearls to pull out for that. Cause I feel like new grads, I think there's so much, because not just new grads listen to the channel and the podcast, like there's experienced people too, and people who are entering primary care from another specialty, right? So it's not just new grads, but like when I think about new grads and I think about what I wanted to do and the people that I work with and what they want to do, there's so much desire to do it all right now. And
Absolutely.
like having conversations like this takes time and practice. I feel like the first place to start is the non-judgmental attitude. Exactly like you said, of like, I had a similar thing in nursing school where it was not about diabetes, but it was about older adults who have visual impairments, tactile impairments, hearing impairments. I wore earbuds. I put on these like really hard to see glasses and I had these big things and like someone's explaining my med regimen to me. And I will never forget that. Like that was impossible. Like, and they're saying it quickly and I can't, you know, like that whole thing. So I think that's one thing to start for, especially for newer clinicians. It's okay to build on this. And then I think one other thing I wanted to pull out about what you said is like, just like meeting people where they're at, because it really is a long game. Because I think especially, I don't know if you had this when you were a brand new NP, but you also had so much other clinical experience before, so maybe it didn't hit you as hard. But like, it's just like, I felt the pressure of like, I have to fix it today. And so I had a diagnosis of diabetes. And I'd be like, okay, monofilament, ophthalmology. Yeah, like it was ridiculous. And I think about it, I'm not saying ridiculous in a judgmental way to a new grad who is listening and is doing the same thing. Like, but it was like in retrospect, it was like that was that people didn't come back. Right. So it's a stepwise approach. It doesn't have to be done today. And like the person coming to a visit who is in denial, like the fact that they arrived is good enough.
Absolutely.
Like we can keep like positive intent, like assume positive intent and assume that everyone is doing the best that they can all the time. Like how does that change the way you approach your patient? Is like that's the best that person can do today. Come to your clinic and tell you they're not doing anything, right?
Absolutely. Yeah, and you do have to adjust for where they're at seasonally. And I tell people too, like when you're diagnosed with diabetes, whether that was yesterday or 10 years ago, diabetes is not like, hey, you got it. I'm going to stay right here. I'm going to be stagnant. This is the worst it's going to be. It is progressive. So, I mean, like, I can't remember the stat on like the beta cell dysfunction and like how much of the beta cells that you lose by the time pre-diabetes is found, let alone type 2. That destruction is gone and that's progressive. So, like, what used to work 3 years ago, diabetes just on this little happy merry way. And you got to jump the fence and you got to get ahead of it, you know, with meds or weight management or whatever it might be. And it might be, you know, like talking about if they have this elevated A1C and newly diagnosed, of course, you can't fix everything in one visit. And depending on where you go, of course, I'm going to be way more aggressive in the treatment than many other people would be. And, you know, my boss would be even way more aggressive. And, but it's appropriately aggressive. But you have to tell them too, like, hey, look, I recognize that you're scared or nervous, but you know, these averages of 300s, if I pull you down to averages of 100 within a week, you're not going to feel good. You know, like I gotta chip away, you know, I just got to kind of knock it down a little bit. And, you know, we can talk about a little bit with meds and kind of some of those algorithms and we'll go to pearls and stuff too, of like, okay, again, people crave success. a lot of, and I know we're focusing mainly on type 2 diabetes, but many patients, most
Mhm.
patients with diabetes type 2 need some type of weight management,
Mhm.
so it could be, you know what, I know, an injectable doesn't sound great, but the semaglutide or Trulicity or something like that, the weekly injectables, it's great. Let's get some success. You can kind of taste that and you build from there with that compliance. But then can
Absolutely.
you imagine, like, let's say that you're on like a med regimen and somebody's told you, okay, check your blood sugar 2 times a day, 4 times a day, whatever, and you're checking it. You don't go back in because they're like, well, they told me not to come back for like 3 months. You're checking your blood sugar 2 to 4 times a day. You're not seeing it budge. You're doing everything you can with diet and exercise. I'd
Mhm.
kind of be like, what's the point? Like, I mean, like,
Exactly. Mhm.
it becomes
Exactly.
completely disheartening for that patient to just be like, well, I'm not seeing progress. Like, why am I still checking twice a day and I'm seeing nothing but 2 to 300? So,
Uh,
there's multiple reasons, but you just think too, okay, when was the last time I had to check my blood sugar 4 times a day and do finger sticks and stop what I'm doing and clean off? And then I need to count my carbs and make sure it's a low glycemic index and pair it with protein and fat. And I need to exercise. Like, can you do that? Can you do that?
I
Like,
cannot.
I
I
mean,
cannot. I try really hard to feed myself well, and it is
oh my
very
gosh,
hard.
absolutely. Yeah, not to mention your family. Like, it's so
Mhm.
hard. It's so hard. So I'd really try to tell people, like, my main thing, and I'll tell them, like, I exercise for mental health. My family history terrifies me, but I also really like to be able to sit here and be like, I do exercise five
I
to seven
know.
days a week. I mean, like, I like to be able to say
Yeah.
that. And
Yeah.
then,
You get what's involved, and you get the challenge.
absolutely.
Mhm.
Yeah. And also, too, it's just we're, as healthcare workers, we have a certain knowledge base. And I always love and respect people that are just like, I don't understand. Like, I call my collaborative MD for stuff that, I mean, she's always very reassuring. She's like, Megan, no, call me anytime. But it's like, if I don't know something, that's okay. But we can't assume that the patient knows what we know. Like, we can't assume that they know that maybe fast food twice a day is not the best option.
Mhm.
Maybe sweet tea or a soda or even half and half tea is not the best option.
Mhm.
So, I mean,
Mhm.
that sometimes can be helpful because it's like, just because we know something
Mhm.
doesn't mean we can't assume that that patient
Yeah.
understands it too, or to understand the impact.
Yeah, and I think even when we talk to patients too, like if we start kind of like at the basics, essentials, most of the time that's going to include everybody. Versus if we start with not the basics,
Mm-hmm.
we're going to miss those people. But then also the people who know all that stuff, they're going to be like, "Oh no, I know." You know what I mean? Like
Mm-hmm.
like
Yeah.
people are quick to correct you, like, "Yeah, I got that." But if you're kind of
Mm-hmm.
like starting from that foundational place, you can kind of see the person will typically volunteer where they're at in terms of their level. Do you know what I mean? Like in those
Mm-hmm.
conversations
Right.
too.
Right.
But I would
And
love
I,
to
oh,
go ahead.
I'm sorry, I was going to say one more thing too about, like, with medications,
Yeah.
because especially with something like, I'll give the example of like a GLP-1. So we know with those meds that we're going to see like weight management and everything. So it's like, what's your approach in communicating with that patient on how these medications work? So, yes, we can say, hey, when you take this weekly medication, it's supposed to help with weight loss. It's going to help your sugars, whatever your spiel is. But it's like, let's try to, like, put it into words of how it actually works. Okay. So what I'll say is, okay, so you're on this GLP-1, and I'll mention the name of whatever one it's going to be, whatever we decide on, with the patient. And it's like, these are intelligent medications. Okay. These are not old school grandma's, like, glipizide, from 30 years ago. Like, these are intelligent meds. So you take this medicine. So let's say it's somebody that's worried about lows, or they're wanting to do a CGM where they can, like, see their patterns with what's going on. So it's like, okay, well, you take this weekly injectable and you take it, and it's like in the background. And it's just waiting on Megan's blood sugars to go up. It's just waiting for you to eat. So then you eat that little sausage biscuit in the morning. What's it going to do? It's going to come in, it's going to help. It's going to help the body release the right amount of insulin, kind of cover that a little bit, but not give you too much where you're going to have this drop. So it's in the background, it's kind of waiting. It helps to decrease your appetite. It's going to help you feel fuller longer. But you know what? If you introduce foods and you eat something that's going to digest more slowly anyway as baseline, chicken strips and french fries, hamburgers, anything fatty, anything fried, any food that's going to slow down digestion anyway, you put this med on top of it, you are going to experience some side effects that might come back up, so it's a good deterrent for not doing that. Because they'll come in, they're like, I have reflux, I have nausea, I've been vomiting. It's like, okay, well, but if they know in advance, like, oh, you're right, every time I eat whatever food, I feel terrible. So I'm going to feel really bad with like this medicine on top. So you kind of give those besides just like, okay, you might experience nausea, vomiting, diarrhea, constipation, whatever. It's like, what does that mean? There's going to be a side effect for aspirin or, Tylenol, but you have to, but how can they take that into like practical knowledge too? So
Totally.
that's just a side. So
I love that. I love that so much. Oh my God.
I can go on 1,000 tangents. So, just.
I was gonna say, I could literally be here all day. I wanted to touch on cost. So I was so grateful. The way that you and I connected was I was talking about one of the things. So I have this diabetes hypertension course. And so I was like, the main thing that I feel less equipped to answer. Like I have my own anecdotal stuff, but I'm in primary care, and like foundationally what I'm teaching is about like pharmacology and all that stuff. But when you talk about, it's the main complaint that people have as providers. And like when I kind of cast that question out to people, like, what do you do to manage costs? You like blew up my DMs in the most beautiful way. I was like, who is this amazing person?
Something I'm very passionate about.
So yeah, I would love for you to share there are so many ways to help people with costs, but what are your thoughts about that? And also we can like, again, write down some more detailed stuff.
Yeah.
Because
I'll send you links and
people
everything.
listen in the car and I don't want them to like, oh God, I've heard this down.
Oh yeah, no. Yeah. I'll send you a lot. So yeah, so when I saw that in your was the Instagram stories, right? You just presented that. I was like, oh my gosh, I gotta blow her up because alert, I have resources. So that is by far, I mean, you can have the best meds in the world, but if somebody can't afford them, good job getting them from the pharmacy. I mean, like we have the best meds that nobody can afford. That group of patients that are just like in that little window, people who have these high deductible medication plans, so they might have insurance, but what if their family deductible is $5,000 to $6,000? So that's really, really difficult. And I know there are really good questions from your audience too about like gap coverage and everything for Medicare. Knowing formularies is super, super important for a lot of reasons, but also too, it saves a lot of time for you and your staff because then you're really hopefully trying to cut back on a lot of prior authorizations and time on the phone pharmacy and everything, and decreases or it helps increase access of medications. So of course, like I was looking back on your stories, a lot of people did recommend like the GoodRx. Okay, so GoodRx is good for certain things, but like really name brand medications, it doesn't take a lot off. When you still have a med that can be retail $800 and it's, a certain amount off, you're asking somebody potentially to pay like 2 car notes worth of a medication for just 1 month. And, nobody, even if you can't afford that, like who really, really wants to do that? So, and then GoodRx too, of course, it's not insurance. So if somebody does have that deductible, it doesn't hit deductible. So it doesn't help them in that aspect, except for if it makes something that's a generic even cheaper, that's really, really good. So all of these big major companies, or I say most of them, and I don't work for any of them. I will blast names. I don't care. I don't get compensated by any of these companies. Not that I would, talking about patient assistance, but I would say out of all of them, the 2 that are easiest to work with for patient assistance programs is Novo Nordisk, which is Novolog, Fiasp is a faster acting insulin, Tresiba, Levemir, Ozempic, Victoza. You can even get glucagon. You can get pen tips on these. There's 2 different things for Novo. Okay. So the Novo Nordisk Patient Assistance Program, that is number 1 for patients without any insurance at all. Okay. So if somebody, it's just, they have no insurance whatsoever and they meet income requirements, and it takes a little bit of time by you or your staff to fill this out. Within 7 to 10 business days, you get a yes or a no on it. And if it's a yes, if it's non-Medicare, it's a year from that date that it's approved. They'll mail 4 months of medications at a time, and you renew the application. Now, before anybody's like, oh, what about, the income requirements? Okay. So, and I told Liz, I'm on my husband's Mac and I don't know how to use it. Let's see, it's below the 400% poverty level. Okay. So this is actually pretty generous. So this really hits that middle class uninsured. Um, so that, for example, for a family of three, it's income below 92,120. I think for a family of four, it's below 100,000, which that's the definition of, middle. So, and then even like family of two, I think it's like 30 something thousand, but I don't have those exact, they change them too. So they did change them for inflation. So that was great. Yeah.
Cool.
So that is for uninsured patients. Now, if somebody did, and I think this is still the case, if somebody did lose their health coverage because of COVID, they're eligible for even getting like 90 days of their insulin for free, for it too, like while there's a gap in coverage potentially. Okay. So this is great. Somebody comes in, they don't have any health insurance at all. They do have programs, we can talk about this, like the federally funded, like the FQHC, the 340B. They might still have a cost associated with that, but a very, very low cost compared to what it is retail. But you can get this, I mean, they can get thousands of dollars of medications. I mean, it's tremendous. You're talking about getting like 4 pins of Ozempic, like that's, I mean, it's incredible. So when we get this now, used to anybody that's already been enrolled, I believe it is, they still have to mail the medicine to the prescriber's office. Now for like new applicants, I think they just ship it straight to the patient. So yeah, so it's 4 months at a time, and the patient has to keep up with their refills. So they ask them for the refill, and then they send a refill request. So you just have to like kind of stay on top of it. So it's paperwork. I'm telling you this, you get patients like free medicines and free good quality medicines. They'll be your patient forever. I mean, like the appreciation that people have from that is fantastic. To stick with the same application, this is also helpful for your Medicare patients too. Most of our Medicare patients are on some type of a fixed income. And even if they have like a supplement, they might not have good Part D coverage, or if they're in the gap coverage, again, it's income eligible. A few years ago, it was a little bit harder to get it, but again, it's not a no until it's like a hard no. And I would rather them take the time and bring us that tax return if they wanted us to submit it from our office, or if they want to do it. And it's not a no until it's a no, and you get that, and you get good name brand meds. You don't have to go for like the cheaper, less effective options at the pharmacy. So that's one through Novo Nordisk. The Lilly company is also a really good one. That one's an easy one to do. And I'm just, each one, like Jardiance has a separate one for like Jardiance and Synjardy. And then Farxiga through AstraZeneca has one. These are the two main ones that I use. Just I found in my experience a little bit easier to use for the patient as well. So Lilly is another one. You can get Humalog through it, Basaglar, and they don't do Lantus anymore, Trulicity. And there's several more even, and keep this in mind, this is for Lilly especially, it's not just diabetes medications. So there's different tier meds, and they list them. And on their application, I believe it's based off of which, like your income versus which group of medication it is, like for the cost. Does that make sense? So like there's like a variable amount, So again, 3 to 4 months of medication shipped to the patient, if they meet that income eligibility. So then Novo Nordisk. So let's say it's a situation that you have a patient with type 1 diabetes and they have a high deductible plan. Okay. So how much is cash insulin? Way too much. way too much. The Walmart released the Rely on Aspart, which is the generic Novolog, so that helps out a lot. But still, if you want somebody to have like good insulin, not having to do N&R, and granted, that's great for what they can be used for, but that's really going to be the last option for me.
Which one is?
Because I want N&R, NPH and regular.
NPH and regular.
Intermediate. Yeah. So meaning they can go to Walmart and pay $25 and get a vial over the counter without a prescription. That's the last, on the list. So Novo Nordisk, you just Google it. It's My 9999, And that is a copay card that you print out. It's you can do it in office, and it's a mix and match for up to two different brands of insulin, not a GLP-1. Okay, so you can get like Tresiba and Fiasp, like a box of each or a certain amount of vials of each for $99 a month. So considering the actual cash price on that, of what the vial of insulin is like $330 per vial, and they can get 3 or 4 vials. I'm going off memory here, but I'll send you all the applications for it for $99. So that's a fantastic program. So that they can have commercial insurance and like a high deductible plan, or they just, don't have great coverage even with the copay cards if it doesn't reduce enough off of it. Because you always want to utilize copay cards and stuff too, but it might only buy it down like a certain. Okay, so that's another one. Then in our area too, and I looked online because you can search by your area. One of our new, and this is newer to me, so I'm still learning about it, but the different programs available like in the rural areas, like the FQHC clinics, and then the 340B insulin 340B clinics as well. So they use them for primary care, and they have their pharmacies. Some of these GLP-1s, depending on which they get in stock, you can get Ozempic for $10 a box. You can get and the price just went up.
What's retail price of Ozempic?
$800, $900.
Yeah. Okay, just for context, especially
for context. Yeah. So, because you can, Ozempic's great, but I don't know if I want to pay that much for it. Yeah. So the same thing with insulin, and it just depends on the brand and what they have available in the pharmacy. The SGLT2 inhibitors, depending on which one they have available, and also the strength. So sometimes they might not have a max dose strength. That again, it's like between $8 and $10 in my area. So it just depends. But all that information is online if you search for 340B or FQHC, like in your area, to help refer those patients to. So those are like my big ones. Yeah, for sure. And then there's also so Januvia, it was supposed to go generic last year. Didn't go generic. I can't believe it. I've been working long enough to remember when it was.
I did not know that. I didn't realize that. Wow.
It was supposed to go generic, but I think it got pushed to maybe spring of next year. So don't quote me on that. Spring of 2023. So that will be a great option too for a DPP-4 inhibitor. Not my go-to, for diabetes management, but a good option. And then also too, unless this has changed recently, the SGLT2, the Steglatro has a really great copay card, right? Steglatro.
I don't know.
That one. Okay.
Okay.
Yeah, and it also comes in a combination with extended release metformin. It's called Segluromet, and there's a combination Steglatro with Januvia called Seglujan. I think they make these names up just to, make fun of us. But so it has a really good copay card that buys it down to $0. Then AstraZeneca. I mean, so you have to kind of know these little nuances, right? So you got to talk to your reps and be like, hey, look, this Zigduo, just to not assume anybody knows, so I'll just pretend like y'all don't know. Zigduo is Farxiga and metformin put together. Okay, so it comes in, a 10-500, a 5-1000, a 10-1000, I think a 2.5-1000. At the first of this year, unless it's changed, if somebody has a high deductible, their copay card will buy down the 5/1000 Zigduo to $0. But if you do 2 of the 5/1000s and just spend $60, they might have an out of pocket. So you might not get the max effect of the medication if you can't get them on a full 10 milligram of the Farxiga equivalent, but you can always max out the metformin, if that makes sense. So you could do a 5/1000 and then 2 of the 500 metformin extended release generic for real cheap and get that cost down to $0 and get a great med.
It's so fancy. And I guess I just want to pause here and say I just want to normalize that it can, I'm just I anticipate the people and what they're going to say and what they think too. And it's it just really demonstrates how frustrating insurance can be. And the medical world can be. And number 2 is that I feel like my approach to I can hear the new grads, my mentees being what? But I feel like the thing is it's almost it's almost like a dedicated project, right? Where it's like,
Oh,
instead of like a
absolutely.
continuing education course about whatever, it's like, it's
Hmm.
almost like it's taking aside that time of like, almost like a continuing education course of like, what
Hmm.
is on, but it's like a whole thing, right? It's like,
Hmm.
what are the options and getting familiar with that, and then you can use it.
Hmm.
And also, I think one other thing, especially in the lens of primary care, that can be bonkers crazy with patients who have more things than just diabetes is like, I just came up on Instagram. Some another account was talking about this, about how they documented their time in their clinic to show to their leadership, to which like evidence of like, you know what, when I work 5 days a week, I do this much overtime, which was a negotiating tool for them to go to 4 10-hour shifts.
Hmm.
And so I feel like in the same lens, again, this is not really for a brand new grad because you're kind of just keeping your head above water. But if you think about like documenting all of the time it takes to, like you said, like do the great work of like applying for these applications and all these other pieces. And you also have results about how it goes down, like it's helped your patient's A1C go down. Like
Hmm.
that's motivating for your clinic to allow you to either have more time to work on that, bring in a part-time staff member to help you be a diabetes liaison, right? We have community
Hmm.
health workers,
Absolutely.
we have
Yeah.
diabetes educators. Like if you don't have that resource, like the way you get resources to support those moving parts is to document it, present a case, and then you get more support.
Hmm.
Either more clinic time, either like less clinic time for you to work on, like more admin time for you, or a support staff member who's going to help be educated in all these pieces and then go forward from there, which I know is
Oh
like a
yeah.
hard, it's like a lot to think about. Again, not really for a new grad necessarily, because you're just keeping your head above water, but like there are ways to do this in primary care. Because I can just hear people being like, there's no way I'm ever going to do that because that's so involved and there's so much time. But I just want to like advocate for like, as you expand in your practice, like we can do stuff like that because our clinics are also motivated. They get, at least in the FQHC setting, if you have an A1C of 9%, they're looking at the numbers of patients with A1Cs of 1% or higher, right? So
Absolutely.
that's actually like, it's again, we all care about patient care, but when it comes to the business of primary care, they need to see return on investment, right? And so if you can document, if you have like a way to do that, right? Anyway, that's just like a very side note, but like
Hmm.
I think that's a real barrier for people in terms of the
Oh
cost
yeah.
is like there's just so much to know and so much to do with it.
Right. And also too, I'm one of those, it's just like if I can streamline something, if I can make my day easier, the patient's day easier, my MA, like I'm not trying to
Yeah,
add 1,000 tasks to her
100%.
back that she already has because of course, we all field a lot of phone calls, a lot of issues with pharmacy and whatever. Okay.
Yeah.
So just something as basic as this. Okay. So it doesn't sound like this big of a deal, but it saves minutes upon minutes upon minutes, which are precious. So how our clinic works, each room off patient room has a remote desktop. Okay,
Mhm.
so we remote into the server, and then that's how we do it. So I have in every single one of my patient rooms a folder saved on my desktop that has every single one of these forms already saved, pre-filled out with the prescriber information, the NPI number, everything, fax, contact information, whatever. And I update it every year when the new applications come out because there'll be little like things that they'll just change here and there. And
Mhm.
it's like I'm talking to the patient and I'm like, oh, okay, well, cost is always an issue. And I'll tell you this too. Even in like if a Medicare patient comes in and I'm talking to them and they're like, you know what, like I can pay X, Y, and Z for my medications. Even if they say that, it's like, why not try? Why
Yeah.
not try to
Mhm.
help them out to like get rid of that copay? Because you know what happens is let's say they're on an Eliquis, which is a high dollar med, or something for RA and a high dollar med.
Mhm.
Those high dollar meds are going to push them into that gap coverage sooner,
Yeah.
which means they're going to be out that 25% out of pocket for those medications.
Yep.
Why can't I do my part to help them stay out of the gap coverage to keep the coverage for the other meds? Okay.
Yeah.
So rant for that. But I have the little folder ready to go. I
Mhm.
print it out. All I have to do is just put the SIG for the meds and all that stuff. And
Mhm.
then you learn really quickly what you have to attach. And it's on them to bring either
Mhm.
take the application completed at home with their tax information, whatever.
Mhm.
And I tell them, like, it's not to get into your business. It's not, I don't care how much money you make. I just want you to have great
Mhm.
meds at little to no cost if that's possible. So
Totally.
then it's like, okay, just bring that back. We can have it on file, and then we fax it in, and then 7 to 10 business days they have it. So it doesn't like just me. The day that clicked in my head of like, why didn't I think about this 5 years? Like I can just have this form
Mm.
already filled out with my NPI and my contact, and it saves so much time because I just print it out and my MA keeps up with it. I fill it
Yeah.
out for the most part. She'll help me.
Yeah.
And then even things like let's say you work with a population that would need something like the My 99 one through Novo Nordisk. And by the way, Lilly does have something, it's called Lilly Cares, I think.
Mm.
So if it's more of like a Humalog preferred, then they have something very similar to it too. So I'm not,
Mm.
and again, it's differentiating no insurance versus high deductible. So
Yeah.
we
Yeah.
got to learn insurance. Okay. So those My 99 ones, excuse me, those are kind of like any other savings card that it has its own like prescription bin number. So
Mhm.
it's not like you do one and make 20 copies of
Yeah.
it.
Yeah.
Sometimes if it's kind of a season that I'm like, man, I'm really going through these a lot. I'll activate print, activate a new one, print, activate a new one. And then each room you have a few of them. It's like take this to the pharmacy and get thousands of dollars of insulin for $99. And they're like, oh, that's incredible. So you just do a few little prep
So
things and it
good.
doesn't have to be
So
this
good.
big whole ordeal. So
Absolutely. Yeah, and I really feel like I love that.
it's worth it.
Yeah, I love that you have a process oriented. I think that that's the thing that saves me in primary care is I do the same thing the same way every time. Obviously
Mhm,
customized per patient, but my process is the same. So
mhm,
I really love that. And I really do want to stress that like it really sounds like because I'm not even familiar with all of these things, right? Like my plan is I'm going to sit down, I'm going to read about them, and I'm going to get my baseline understanding familiarity, and then I'm going to say like, okay, like what is my process to make this easier? Right.
mhm,
So it's
right.
worth the time of initial learning, and then it will become more rote for
Mhm.
people. Well, I do want
And
to be
I'm
mindful of time. Oh, sorry, go ahead.
Oh, I was going to say one more thing about the GLP ones. For the cost by far, I find that that's the most difficult one to get at a good price if it's a deductible issue, especially, or if it's like a cash pay, and if they don't, especially qualify for like the free one based off of income.
Mhm.
But and I think we're going to talk if we have time about the newer medicines like that are on the market, like the new Monjaro. It's not on formulary yet, and that's
Mhm.
a really really great option that like regardless of insurance coverage or deductible, when you talk to the reps, and at least here, and I'm assuming it would be the same nationally, you can get 90 days of a great new meta GLP-1 that's new on the market for $25. So
Wow.
it's like some of
Wow.
these newer meds. When Rybelsus first came out,
Yeah, yeah.
regardless of insurance, you could get it for $10 or 25 or something like that. And now, once it was on formulary, I had these patients on Rybelsus, and we had to figure out a plan B for that. But it's like at least in the interim, because you never know if that person gets a new job change or whatever, you still want to advocate for like the best meds at the best price
Totally.
possible.
I
Yeah.
love that. Well, yeah, I do want to be mindful of time. I think a great closing place would be is even though I have like 1,000 more questions I could ask you, is like what like pearls, like whatever feels best for people, like what pearls do you have for primary care? Like another way to think about that or look at that is like what do you wish primary care providers knew? But either side of that coin of that question, like whatever you want to share for pearls of practice and all that.
There's there's several, and I I love primary care. I love primary care. I'm like, go back to primary care. We love primary care. I'm not your primary care provider. Like, please go back to them. Like, yeah, if you're not seeing them for 6 months and your lipids are crazy and blood pressure, I
Mhm.
absolutely adjust meds and prescribe hypertensive and hyperlipidemic meds. But it's just please go back to primary. So thank you for what y'all do. Thank you. So one of the things that I would really make sure, especially, and this is getting back to like the language of how we talk to people and everything. And I think that I really feel like this has gotten better over time, but we have got to get away of thinking that insulin is a punishment. Insulin is not a punishment. Insulin's not a four-letter word. It is not, you're being a bad diabetic. Like, first of all, talking about saying like non-compliant, like we don't say you're a diabetic. I mean, to
Yeah.
me,
Yeah.
no, you have diabetes. It's not
Personal.
like you have this. Yeah.
Absolutely.
So no, you're not brittle. You're not a bad diabetic if you need insulin. Again, it's the tool in the toolbox. So we don't want to use that even as like a threat. Like if you don't come, if in 3 months, if you come back and your A1C is still elevated, I'm going to have to put you on insulin.
Yeah.
And then so they might come see me. I'm like, let's do it today. It's not a punishment. It's a way that I can get you safe in a relatively quickly manner. That's
Mhm.
a variable amount that can be adjusted based off of what your needs are. That
Yeah.
might not even be permanent,
Yeah.
right? So it's
Yep.
not something that that's like my favorite pastime is taking people off insulin. Like it's so much fun. So
So
that's one thing.
great.
And
It
just
really is. It's
yeah, take people
amazing.
off of meds. Don't just add meds. So that's one thing. Is like let's not use insulin as a punishment. I will say too, and this is just kind of my practice on like when you're looking at the algorithms and everything. And I was looking back at some of your old YouTube videos, and I love that you referenced the ACE guidelines.
I like
I,
ACE.
I love ACE. Their algorithm is so pretty. Like we need to make sure that everybody has a link. It's so pretty. It's so beautifully done,
Yeah.
and
So
it's
easy to
very
follow.
easy to follow. So
Mhm.
easy to follow.
Mhm.
And one
I'll
of the
include
things
that
that,
down below this video
oh
too.
yeah,
People can link to it. Yeah.
there is also a way to get those like laminated pocket size, and I think you can get them from Ace. I think so. That's really handy too.
Oh, I'm gonna look at
So
that.
they're like really
Little
small
pocket
because
size.
there's
I
also one
love
for
that.
hypertension and hyperlipidemia. Yeah. So
Yeah.
I love the ACE guidelines. But when you look at it, obviously with med management, like on there's a big part that's like regardless of A1C control, if there's the ASCVD risk or CKD or heart failure, you have
Mhm.
somebody on like on the SGLT2.
Yep,
Okay,
yep.
so for patients who are, or for I'm sorry, for your MPs that aren't quite as familiar, that's
Yeah.
Jardiance, Farxiga, Stiglatro, which is one we talked about earlier. But
Mhm.
how sometimes what happens is the patient might come in and maybe they're like new to primary care or just somebody that's kind of hit or miss. They might be like on, mid-range or maxed out metformin and an old school like sulfonylurea. Maybe
Mhm.
we still have a lot that are on like pioglitazone, like Actos.
Oh,
And
wow.
so maybe it's a cost issue or
Yeah, I
something.
was gonna say that's one of the cheaper options. So funny you're
Right.
in that class, yeah.
Oh yeah, for sure. So those are strong meds. Those
Mm,
are strong meds. And they're not like the newer, more intuitive ones. But so sometimes patients will come in, they'll be like, well, I was on Jardiance, but it didn't work for me. I'm like, okay, well, what else happened at that time that Jardiance was prescribed? Like,
mhm,
oh, well, they took me off of glipizide and Actos. Well, if you have somebody like on a max dose of a sulfonylurea,
mm.
that being as strong as it is, stimulating that insulin production, assuming that they still have beta cell function, that is hard to get off of. If you have to titrate slowly off of that. So if somebody
Good
comes in and
point.
you're like, I'm going to add, but then
Mm,
you take away,
mm,
those sugars are going to go up, especially if you're titrating up the GLP-1. So if
mm,
you have somebody that's on glipizide, extended release, and they're on 20 milligrams a day total, sometimes that or even higher can be the equivalent. And this is just what we see clinically, not necessarily in literature, like 20 to 30 units for some people of insulin. Like that's how strong it is.
oh, that's
So
so
there's like this,
context. Yeah.
yeah. So it's like, okay, well, you know what? Your A1C is a 9 or an 8 or whatever. These meds aren't working. Let me take you off of them. Which, yeah, that would be the goal while you're adding and titrating up on some other ones.
Mm,
But their sugars are gonna, for a
mm,
lot of people, go higher. So we want to think of that too. Is like, are you just like adding on to therapy while like decreasing slowly? Like really think about the mechanism of action of these medications and like how strong and how potent they are.
mhm,
Because yes, you're going to get great results with the SGLT2, GLP-1, but if you take away max doses of others at the same time,
yeah.
you're not going to see much success
Mm,
on there too. And
mhm,
just another thing that this is kind of what I try to think of, and I educate the patient too, is I like my go-to, of course, metformin. Yeah, metformin. Okay. GLP-1. Love a GLP-1 at first,
love GLP.
especially if they're high. Yeah. If
Yes.
I if I have somebody come in and we do a baseline UA, when they come in and they're not on an SGLT2, okay. I know I need to put them on one, but if they already have 3+ glucose in their urine and
Oh,
you have the higher incidence adding an SGLT2 with the yeast infection or urinary tract infection,
mhm,
do I want to add something at that point that
mhm,
can potentially precipitate it and increase it, knowing that I can add it later,
mhm,
right? So
mhm,
if somebody's coming
mhm.
in the real high, what I'll do too, I don't want to start a med that gives them such a potential side effect or issue that puts a bad taste in their mouth and their brain of like,
Yep. Can't do that
that game
ever
that
again.
no, can't do that.
Yeah.
Jardiance gave me a yeast infection. It's like, well, your sugar was also average of 300 and you were drinking like 5 sodas a day. Like, was it really the Jardiance? But if that happens, who wants to be on the med again that gave them a terrible yeast infection? So I'll a lot of times will pull them down and then be like, I want to add this med. It has the CKD that I don't say CKD, but it has helps your
Mhm.
kidneys, helps your heart. You have this, but I really don't want you to have X, Y, and Z happen. So let me pull you down and then I'll add it on later. So that's
Mhm.
kind of just another little pearl too.
Love
And
that.
and then one more, let's see, I had written down a few, is with insulin. One of the questions when we were first talking, I think you had presented like, is there like a max dose of insulin, which I know
Yes,
you'll
that's a
get.
great
Yeah,
question. Yeah,
yeah.
I love that.
So insulin, I mean, we're all taught in nursing school it's a critical med, right? Like, so two people check off on it and all this, and you're like in the hospital and you're checking off like 2 units of Humulin R, and I'm not disrespecting that at all. And then you have, I have people on U500 insulin that's 5 times concentrated and it's on 300, 400 units per day. So, you still have the respectful fear, right? But you're trying to think too, it's like when you have, or let's say you have like the CGM data in front of you, like what do you think about? What am I trying to fix? Right? What am I trying to fix? If we say, hey, your A1C is a 9, but what if they come back and they're like, you know what, and let's say they're not on the CGM, they're like, well, my fastings are like between 90 and 120,
Mhm.
but so is the answer to just keep increasing the basal insulin? Now,
Mhm.
number one, the answer might be changing the basal insulin, get out of the glargine and detamere and do more of like the a longer, long acting insulin, like
Mhm.
Tresiba, 42 hour, like it's fantastic. It's beautiful and it's more comfortable. But
Mhm.
is that answer to just increase basal? Because what's going to happen to those fasting numbers,
Yeah.
right? So they're just going to go lower. We have to remember that, sorry, these went out. Most of I can't remember the percentage. Most of an elevated A1C is due to like postprandial
Yeah.
surges.
Yeah.
Okay. So you get the GLP-1 on board, but the answer is not just to increase basal. At some point you need to be like, okay, you're at zero point 0.5 units per kilo on this. Like that's
Yeah.
too much. It's time to add in a mealtime insulin at that point too. Now, a lot of facilities don't do sliding scales. We do,
Yeah.
obviously, we do carb
Yeah.
ratios, sensitivity factors and stuff. And then we always want to say, prevent the problem, don't just treat the problem. So if
Mhm.
they're 90 here and you're like, okay, well, how about this? Check 2 hours after you eat breakfast. And if you're 250, take 3 to 5 units or whatever the scale. Okay, what's going to pull them down? How do you prevent the 250? Right? You're still not getting ahead of it. So
Mhm.
you want to get ahead of everything. So that's when you need to really start going to that prandial insulin.
Yeah.
And then once they get on those higher doses, start considering doing the concentrated insulins too.
Yeah. And just for people, like I've just been head deep in all of this. And so I'm like, yes, yes, yes. But I'm just thinking about some new grads who are like, what? For some of the parts, not that I feel like that was very clear, but recently I've getting more comfortable with the more concentrated long acting
Mm-hmm.
one. And so just to
Yeah.
pull that piece out, you have Semglee, Basaglar, Lantus. Those are like the brand names. Yeah, those are not the generics.
Mm-hmm.
And then you've got Tresiba. Again,
Mm-hmm.
I'm not affiliated with any pharmaceutical companies either. But Tresiba is it's basically the long acting
Mm-hmm.
insulin. And then you also have concentrated, certain medicines have certain concentrations that are higher. So
Mm-hmm.
like you're saying U500, are you talking about
Mm-hmm.
regular U500 or
Yes. Yeah.
yeah.
So U500 is its own kind of thing. It replaces basal and bolus. Okay. So if you have, let's say you have somebody on, let's say like Lantus. Okay.
Mhm.
Lantus burns, glargine burns,
Oh,
it's
really?
acidic. Yeah. So
Oh.
like that's not a very comfortable injection. And
Mhm.
I always ask patients about that. Like, nobody loves to give themselves an injection anyway. I'm like, do you feel that? Does it burn? And people are like, oh my gosh, it burns so bad. Like it feels like a bee sting for a lot of people. So
Oh.
then you want to try to get somebody on a more comfortable injection. That's usually why I go the Tresiba
Mhm.
route. For most people, it's, yeah. But then think too, okay, so you have like a large dose of Lantus, you know. So if you dialed up that pen and it was like 80 units and you squared it out, it's like how much liquid comes
Yep,
out
yep, yep,
to be
yep.
sub-Q,
Yeah,
right? So
yeah.
that's a lot. So at that point, if it's starting to get uncomfortable for them, or if you're even considering having to do like twice daily
Mhm.
long-acting insulin, that's
Mhm.
when definitely go for like a Tresiba because it's on formularies for a lot. And then also Toujeo is a U300. I don't know if you've,
Lovely. Yeah,
yeah,
yeah, yeah.
yeah.
Yep.
So Toujeo is U300. So the
Yeah.
smaller pen has the equivalent of 450 units.
Yeah.
The larger pen has 900.
Okay.
The 3 ml pen of the Tresiba U200 has 600 units in it. So you do have to convert it to the pharmacy.
Yeah. Yeah.
Safety, 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 safety on this is just okay. So there's warnings on the hair dryer to don't take a bath while you're blow drying your hair. I
Yes.
mean, somebody did it, right? Okay. So most of these, because there's also a Humalog U200, and then
Yeah.
there's a Lunjeb, which is a faster version of the Humalog, a U200. And
Mhm.
on those, there's like these little, they're yellow stickers. It says, do not draw out with a syringe, because sometimes patients do run out of pin tips, the little twisty pin tips.
Oh, I see. I see.
Yeah.
Yep.
So if this is converted down by volume. So you're not changing the unit, the pin changes the volume.
Yeah.
So if they're on 80 of Tresiba and you put them on the U200, if you compared it, it's going to look like 40 units by volume. If that makes sense. So you're not
Oh,
saying,
please.
yeah,
Oh, that's
so
so
each one
bad.
is, yeah, so it's
Um,
half of the volume because it's
yeah.
concentrated.
Yeah.
Okay. So if they're like, oh, I ran out of pen tips, and they get a little insulin syringe and they're like, ooh, let me just pull this out. And they
Ooh.
pull out 80, they're getting double, they're getting
Oh
160
my
because it's by
goodness.
volume. Yeah. So
Yeah.
that's the safety part on that. They're fantastic. I don't want that to like scare people from not using because it's such a more comfortable injection. They're not getting as much of that
Volume.
volume sub
Yeah.
Q. Yeah. And then total, I'll touch on that U500 a little bit when our clinic first opened, again, the U500 was on the market, but we
Yeah.
had to convert it down by volume, either in a TB syringe or an insulin syringe. But
Wow.
now the U500, it's a teal pen, and I will say on their website, and I double checked last night to make sure that the prescribing information is there. There are 2 or 3 great tables on the prescribing of this. Okay, so this is typically used whenever the total amount of insulin per day is 200 units or greater. Okay,
Mm.
so meaning if they're on 10 unit or 20 units of Humalog a few times a day, plus a lot of basal insulin, and it equals 200 or more, this is a great, great, great insulin to help
Mm.
with just reducing the amount of injections because you can start at BID dosing. So you
Mm.
can go from potentially 2 Lantus per day if they're on a split regimen and 3 mealtime to 2 times per day. So you
Oh,
reduce six
wow. So you get rid of the
and
prenatal and the long acting and just replace it with this
right.
one. Cool.
And it's not a mixed insulin. So U500 has a much longer duration.
Mhm.
But then you can reconvert it. But there are really good tables on the prescribing of it. But what's scary is I did an example. Let me see if I can find it. Because then you're like, ooh, it's so I took it as because it's a straight conversion if their A1C is over 8. And that's when you're like, that's a lot of insulin. So
Mhm.
if they're on a straight 200 units per
Yep.
day, and you want to start with an easier regimen and they give you the dosing on it. So it's 60% in the morning, 40% at night to kind of start.
Mm,
60% of 200 is 120 units that you would dose that person at one time, and then 80 in the evening. So you look at that and you're like, yeah, like, oh wow. But it is, and I remember the first time I had to put my name on a prescription of that, I'm like, oh my gosh, please make sure I did this math right.
Please.
And it's right. I mean, it's to the T. And so that too, especially if things like this, you want to think of, if somebody's practicing in a rural area that they don't have
Mhm.
access to endocrinology or
Yes.
they don't have,
Yep.
you need to know how to do
Exactly.
this. And
Exactly.
but then they have that again, really, really tables. I have put screenshots on my phone and I have like a saved photo album for it of just because they tell you, hey, if the average fasting is below or above, this is the dose that you increase, and then by what percent. So they give
Amazing.
it to you
Step by
like step
step.
by
Yeah.
step.
And I guess I just want to pause and say, well, two things. One is that most insulins are 100 per ml. The concentration is
Mhm.
100 units per 1 ml. And so whenever you
Right.
say U200, U300, U500, it's just 500 units per ml, correct?
Correct.
And
Correct.
then
Yeah.
something happens when you have more concentrated insulins that it changes the pharmacokinetics because both because of the volume and because of the concentration. And that before I actually say any more, I want to normalize for students and newer grads and people just switching into primary care. This is advanced diabetes management.
Oh yeah, sorry, I went.
That's okay. No, it's beautiful, right? Because it's not just new grads that are watching and listening. And it's so helpful for me. I love this. But like unless you are a passionate diabetes person, and also you have more years of practice, you're probably gonna like ease into this. But like, yeah, like the concentrated longer acting ones are just wonderful. And it's Humalog is U500. That's the right name? I'm saying that right, correct?
It's Humulin R U500.
Oh, Humulin R U500.
U500. There is a Humalog U200.
Okay.
Yeah.
Yeah. So it's like a shorter acting one but when you put it in that hyper concentrated formula, the pharmacokinetics are different. Is that correct?
Right. Yeah. Because I was reading even about it too, because it's almost like misleading because you look at it, it's like, okay, Humulin R, but it's just a concentrated. So is it a concentrated regular?
Exactly.
But it's not. Yeah.
Right.
So it's a long tail. I mean, long tail on it. Yeah. That you can see.
Yeah, that's really good to know. So I think for students, newer grads, ask for help before you do that. Once you have more practice
100%.
or you're really passionate about diabetes, it's beautiful. This is really, really helpful because again, like I have many years of practice at this point, and I'm interested in expanding more of my diabetes care. And it's such a good point you said about rural medicine, because so many clinicians say, like, I just can't get people to a specialist. What am I supposed to do?
Absolutely.
And I think safety first is that, like, if you're a new grad, you're still a new grad, even if you practice in rural medicine, you probably still need support. And also you're probably going to expand your practice to a place that is really serving people to that maximum level of your license, but it's going to take a little bit of time. So all of this stuff is just so beautiful to share. Thank you so much.
Oh yeah.
Like I said, I have so many other questions, but we'll wrap up this interview and perhaps there'll be a part 2. But yeah, thank you so
yeah.
much. I really appreciate it.
Oh yeah. Thank you so much for having me. It was great. Love it.
Totally.